So before we get on to the future, I want to ask you, so we now have obinutuzumab, we've had ibrutinib with rituximab, other combination of use up front, but I'm continuing to hear about patients actually starting with immunochemotherapy. Do you think there's a reluctance to move to these? I mean, a lot of oncologists will say, I want to save those. We know that they're effective in the relapse setting. I don't want to get to those now. I want to use chemotherapy. Kind of getting at what you said. What do you do when they progress after those drugs? So
Right.
what would you say to someone who still wants to use immunochemotherapy up front?
So I think this is a very different discussion than the relapse setting. So that to me is very clear that we should not be using chemoimmunotherapy in the relapse setting. I think it's much more murky in the frontline setting right now because I think there is still a role for chemoimmunotherapy. I think we need to be smart about where we use it and when we use it. So the first thing is that if you're considering using chemoimmunotherapy for frontline CLL, you have to test for FISH and TP53 status if you can, and IGHV status, because those are all the key variables that go into the equation on trying to decide, is chemoimmunotherapy the best regimen for my patient? And so, for patients with TP53 dysfunction, chemoimmunotherapy clearly not the answer.
Right.
Now, what about patients with unmutated IGHV? So there we have robust phase 3 frontline data now of ibrutinib against FCR, actually ibrutinib rituximab against FCR, but the rituximab probably doesn't add too much. That's the ECOG study. Then we also have ibrutinib versus BR in the older patients, that's the Alliance study. And in both of those studies, there's very dramatic PFS benefits for the unmutated IGHV patients who get the novel agent-based, ibrutinib-based regimen. And so I think that's pretty compelling evidence. Now you could make the case even in the unmutated patients in the Alliance study that there's no overall survival benefit. Mm-hmm. Now that study did allow crossover. So I think you can kind of argue that one both ways for the older patients, that you might still be able to use BR and then use ibrutinib at relapse and the patients will live just as long. But I still worry about clonal evolution and myeloid neoplasia and some of these other longer term effects. And we don't have long-term follow-up yet from that Alliance study. Now in the frontline setting, it's a little bit different for the young patients because there was actually an overall survival benefit to the ibrutinib arm of that ECOG study over FCR. And that benefit really was confined to those unmutated IGHV patients. Yeah. So for that group, I was initially a little hesitant to use ibrutinib for the young patients, especially because of the idea of the continuous therapy. But it's hard to argue with an overall survival benefit for that population. And so even for my younger patients who have unmutated IGHV now, I think about using ibrutinib.
Yeah, but let's turn it to the mutated younger patient with a mutated CLL. There's the MD Anderson data, German data, I think Italian data, all suggesting that in that population, we may actually see a kind of a plateau on the overall survival, progression-free survival curves out 10, 15 years with immunochemotherapy.
That's exactly right. And so that's the one group right now that I still firmly believe that we should be offering chemoimmunotherapy. Young, fit patients with mutated IGHV, they can get 6 months of therapy and potentially be functionally cured of their CLL. We do have to counsel them about some of the long-term risks of FCR, long-term myelosuppression, myeloid malignancies, which are rare but can happen. And so I think now it's interesting because we have Ven plus Obin that's come along, and we have a different time-limited regimen that we don't think has any of those longer-term risks, but we also don't know what the long-term follow-up is going to look like and if there's going to be a plateau or not. And so that's where I was saying it's getting a little bit more murky in that respect.
Worth doing a study of obinutuzumab versus immunochemotherapy?
Yeah, and there's studies like this that are in the works. Okay. It's going to be, I think, challenging though to randomize patients in that way.
Yes.
So, yeah, so it'll be interesting to see how that goes.
Yeah, it will be.